Good afternoon. I'm Professor Margaret Gardner. I'm the President and Vice-Chancellor of Monash University, and I'm very, very pleased to welcome those who are joining us from within Australia and around the world to this very important seminar with wonderful speaker. Let me begin by acknowledging that I'm speaking to you from the lands, the unceded lands of the people of the Kulin Nations, the Wurundjeri and the Boonwurrung peoples, and pay my respects to their elders, past and present. May I also welcome any Aboriginal and Torres Strait Islander people who are joining us online and recognise any Indigenous peoples from other regions who may be joining us. I'm really pleased to welcome you to this seminar hosted by the Centre for Development Economics and Sustainability in the Monash Business School at Monash University. And it's my great pleasure to introduce to you the guest speaker, and a very eminent guest speaker she is. Professor Esther Duflo is the Abdul Latif Jameel Professor of Poverty Alleviation and Development Economics in the Department of Economics at the Massachusetts Institute of Technology. She's also co-founder and co-director of the Abdul Latif Jameel Poverty Action Lab. As I'm sure many of you know, in 2019, she was awarded with co-laureates Abhijit Banerjee and Michael Kremer the Nobel Prize in Economic Sciences, and such a prestigious recognition of such an important body of work. In her research, Professor Duflo seeks to understand the economic lives of the poor and aims to help design and evaluate social policies that cover health, education, financial inclusion, environment, and governance perspectives. And you cannot be engaged in a more important field, because the one thing that has been with us for centuries, taking slightly different forms in different nations, is poverty. And we know that any other crisis we face, whether it's climate change or any crisis that might happen, small or large, in any place that we are staying, will actually have its biggest impacts on those who are disadvantaged. And so this work is incredibly important, because any crisis will exacerbate inequality and very heavily impact the disadvantaged. With her co-author, Abhijit Banerjee, she wrote Poor Economics, a radical rethinking of the way to fight global poverty. And that book won the Financial Times and Goldman Sachs Business Book of the Year award in 2011. It's been translated into many, many languages. And most recent book was Good Economics for Hard Times. And the thing about poverty is there are always hard times. Sometimes those of us who are more advantaged find that we face hard times, but we have to remember that if you are poor, it is often intergenerational and the hard times stay with you. Professor Duflo has been recognised in many different ways. Apart from the Nobel Prize, she's won the Princess of Asturias Award for Social Sciences in 2015, the ASK Social Science Award in 2015, the Infosys Prize in 2014, the David N. Kershaw Award in 2011, the John Bates Clark Medal in 2010, and a MacArthur Genius Grant Fellowship in 2009. Professor Duflo is also the editor of the American Economic Review, a member of the National Academy of Sciences, and a corresponding fellow of the British Academy. It is truly wonderful, because we know that there are rather less of them than we would like, to be able to welcome a female economist and Nobel Prize winner, very rare on in many ways, to speak to us so persuasively about this very significant area of economics, and area for us all to be concerned about in our lives. Thank you, Professor Duflo.
Thank you so much. Thank you, everyone. happy to welcome you. Thank you for your hospitality, or however virtual. And I'm going to share my slides to talk to you today about, in some sense, how I spent my pandemic vacation. So in other words, a series of projects that, along with colleagues, we worked on from the very beginning of the pandemic lockdown, to understand how it was possible to communicate to people, to help them understand better how the disease works, what it does, and how they can protect themselves. So when the world shut down in March of 2020, there was no vaccine yet. And really, unless you were Australia or New Zealand and you could try to shut down yourself to the rest of the world, the only way that you could protect yourselves against coronavirus was through individual behavior change, social distancing, mask wearing, hand washing. And even today, we have a vaccine, but people still need to take it up. And effective communication of public health information remain critical. So from the very beginning it turns out that in much of my career as an economist, I've studied the issue about how we convince people, and in particular poor people, to undertake a preventive health behavior. So for example, I have a lot of work on immunization, not against COVID-19, but against childhood diseases, how to convince parents in India to get their children immunized. And I've done other type of work on preventive health in this way. Nutrition, adoption of clean stoves, etc. So when the world started facing the coronavirus crisis, and the only thing people could do was this preventive action, and there was also a lot of information and disinformation that was circulating, I thought it was very important that basically I pivot my entire research agenda to start thinking about what do I know and what do I need to know in order to inform effective communication for public health information. And I was not the only one at all. Some people in Monash themselves, including my host, have done research on this topic. And we did this work. We started this work with excuse me. We started this work with a group of people at the Jamil Poverty Action Lab at MIT, Abhijit Banerjee, Ben Olken, Arun Chandrasekhar, Marcella Alsen, who had all been a little bit involved in this social information, communication, public health information diffusion. And we wanted to try and quickly roll out effective behavioral change campaign, as well as gather more information that could be useful to government about how to conduct such campaigns. So one of the things that started in March of 2020 is that everyone, not everyone, but many of people you could call credible people, such as doctors, official doctors like Dr. Fauci in the US, started to try and convey the most relevant information and advice. And there was also some stars, TV stars, sports stars, etc. Also took up to advertisement as well as social network. And we also had people using, maybe a more local notoriety. For example, doctors trying to speak as doctors. So this raises several questions. The first one is that in an environment where people are receiving so much information and disinformation, where in particular for the poor people it might be very difficult to understand what is relevant, what is not, does this kind of light touch campaigning via short advertisement or social media makes any difference? Or does it get drowned in the noise or in the politics? The second set of questions is, if you're going to do such information campaign, Do you need to tailor your information to particular groups? For example, do you need to communicate differently towards the poor people, towards rural people in India or in Bangladesh, towards African American in the US, or can you have one campaign for everyone? This is important because if the latter is true, then you can really scale up very simple messages. If the former is true, then you need to think, from context to context about how to develop the effective communication campaign. So this is basically the question we started with in the spring of 2020. And we started working in India in the first place. Our first study we called the banerjee effect. That's not its real name, but that's how we call it between ourselves, for reasons that are going to become obvious in a minute. So in India, had a very harsh, very quick lockdown in late March, early April, which started being loosened in early May. And this particular intervention took place at the beginning of the loosening, and the 4th and the 5th of May, when in India, they just started talking about mask wearing. At the time, the population was absolutely bombarded with messages about COVID-19. For example, in the survey we conducted, people told us that they had received up to 20 messages on social distancing in the last 2 days alone. There were marketing jingles, hand washing from messages from soap manufacturer, public service announcements, text on their cell phone, etc. So in this context, people actually had reasonably good information on the coronavirus, but not very good compliance to the behavior. Only 2/3 of them, for example, claimed that they washed their hands with soap when coming home from a trip outside, which is probably at least twice what it is in reality. So that's fairly low. So in this context, would an extra unexpected nudge from a reliable source improve compliance? That was our question. And our first problem was to find a reliable source. And then it turned out that we had one on the research team itself, because Abhijit Banerjee, who also won was one of the co-laureates of the Nobel Prize in 2019, is a widely recognized figure in West Bengal. India in general, West Bengal in particular, take their Nobel Prizes very seriously. Abhijit hails from there. So he is really a well-known figure. In addition, he's the chair of the COVID-19 Scientific Council, so he has a little bit of the position of a government official position, a bit like Dr. Fauci, although he's not a doctor. So what we did is that we had Abhijit record the small videos on his cell phone, on my cell phone really, and we sent those videos through cell phone through SMS messages to 25 million subscribers of one particular phone network, the Jio phone network. This was done as a randomized experiment. 25 million people received the message in 1200 cell phone, 1200 pin code in West Bengal, randomly chosen out of 1264 pin code, which left us 3 million control people in Jio. In addition, we also collected data on non-Jio subscribers, so we can look for spillovers for non-treated people in treated villages. We only used Abhijit as a messenger, so we are not able in this study to look at the impact of choosing him as a messenger versus choosing someone else. But what we did is that we varied the nature of the message. The reason we made this choice is that we were pretty convinced that this was our best foot forward. We wanted to make sure that to do the best, because we saw this also as an intervention in and of itself. It was done at scale, 25 million people. We wanted it to work as much as possible, and what we weren't sure about is how effective would different messages be. So we always used Abhijit, but we varied the messages. For example, to motivate the message, we either use an externality argument, which is by protecting yourself, you're protecting the weaker member in the communities, or an internality argument, which is, some people get really sick from COVID and you should protect yourself. In terms of data, we collected the data by calling the field workers, the ASHAs. So ASHAs are the frontline field worker. In normal time, they are responsible for maternal and child health, but during the COVID epidemic, they were redeployed for COVID work. And importantly, one of the things they do is that they are supposed to do symptom tracking. So one of the messages that we gave that we told people, everyone, is if you have any symptom, you have to report them to the ASHA. So one of our key outcomes is whether more symptoms get reported to the ASHA. We collected this data within 5 days of the treatment to make sure that the reporting is not mixed up with the direct effect. In addition, we were looking for a database. At the time, there was absolutely no systematic collection of COVID testing. So we're looking for a database to find out about self-reported behavior. And we did that by collecting a random sample from public phone directory of previous and current village council members. So it's a large-scale public directory. We asked about them and also about other people in the village. So what we found in this paper is that the treatment doubled the reporting of symptoms. So people were about twice as likely to report symptoms to the ASHA in treatment versus control villages. We know it's a reporting effect, not that we increase COVID, because it was within 5 days. If you look at the other behavior, they all improved, although from much higher bases, so they look less impressive. The other key finding is that what was said doesn't really matter very much, and you will see this is pretty much a constant of the series of projects I'm going to present to you today, is that reaching out to people via videos does matter, but the exact content doesn't seem to matter as much. So the behavior doesn't seem to be influenced, for example, by externality versus internality, by or other variations. An additional result is that there was large spillovers onto the behavior of non-geo subscribers who did not receive the video, which means that there is a multiplier effect of this type of information. It suggests that there are potentially significant benefit from continuing messaging campaign by credible sources, even when you think that everyone should be informed. So it should kind of continue. Of course, we don't know if the same message would have worked by a less credible source, but since Abhijit remained available to the government of West Bengal, he basically carried out a series of this campaign along the epidemic, 3 or 4 of those campaigns as the epidemic progressed in West Bengal on various topics. And we were pretty reassured by this first study that it matters. More or less at the same time, so this is to show these are rural people in India, in West Bengal. At the same time, we were also concerned about disadvantaged community in the United States, and in particular by African community and Latinx community. So we conducted, I'm now going to show you data from 3 studies that we conducted in the US. One was exactly contemporaneous to this one, and the other a little bit later. This is roughly the same group of people, plus doctors from MGH, and all 3 studies are published in medical journals. So in 2020, there was of course a pandemic, a COVID-19 pandemic that we all know about, but doctors call it a syndemic. That is the combination of the pandemic plus a systemic racism epidemic. In the US, the Black American are 1.4 times more likely to have COVID. They are almost 4 times more likely to be hospitalized and almost 3 times more likely to die. So this raises a question about whether the current way of reaching out to African Americans is sufficient, whether part of this gap is due, of course, has nothing to do with African Americans' behavior, but it has to do with the fact that they had to continue working, that social distancing is more difficult in close quarters. But part of it might also have come from the fact that the information was less prevalent in this group, and also that maybe the regular channels of information were less trusted. in particular in the US when the administration was originally the Trump administration. So many physicians have tried to reach out to people directly to encourage social distancing via, for example, social networks. And so this raises the obvious question of whether this is an effective thing to do, whether it effectively reaches Black Americans who bear the biggest burden of disease, and whether anything needs to be done to tailor the communication for Black Americans, whether you need to change the nature of the message or the nature of the messengers. So that's why we conducted this study. So unlike the US, the India study, which was immediately started on a very large scale with 25 million messages, the US study were started on a smaller scale, still large by medical studies literature, but 11,000 subjects in the first experiment and about 20,000 in the second experiment. And the experimental design was more involved. It involved several variations, etc. I have a video, but I'm worried that I did not ask to share the noise. So maybe, oh yeah, it's here. I'll give you an example of some of the videos we are showing.
Hello, I'm Dr. Kwete from the Massachusetts General Hospital, and I'd like to tell you a little bit about coronavirus or COVID-19. COVID-19 is a new virus that can infect the respiratory tract and lungs. Although many people who get sick from COVID will get better, some people who get it become very ill and some even die. Although there's no cure, there are ways medical professionals have found to protect you and your community from COVID. I hope that this message can give you information that will help you protect you or someone you love from COVID infection. First,
etc. So this continues. So this is an example. This is a young doctor at MGH. She's black. She's wearing her doctor garb. She's now talking about the first video, which is an introduction and the symptoms, some information about COVID-19, including the symptoms. What we did is that we had 3 videos. We varied different aspects of the message and the messengers in ways that I'm going to describe in a minute. And then we surveyed online to measure the outcomes. So in the first studies, we were interested in knowing whether the videos, the doctor videos had any impact. But also whether the race concordance between the doctor and the respondents have an impact. So for example, for the black community, is it important that it's a black doctor? One of the collaborators in the study is Marcella Alsen, and she has shown that it matters when your actual physician is that treats you is black. Black Americans are more likely to undertake, for example, preventive care. So we were interested to see whether that carries over to this type of work. Does acknowledging prior injustice or economic insecurity have an impact? For our second videos, we actually took the text of a public service announcement that was originally delivered by a White House representative, Dr. Deborah Birx, who is very unpopular in the African American community. We wanted to see whether that was less effective or more effective than to have an MGH doctor. And finally, whether belief and behavior on mask wearing change when informing respondents of other beliefs. So this last piece of information came about because at the very beginning of the introduction of masks, you probably don't, we have forgotten that, but it wasn't always the case that we were encouraged to wear masks. They were rare originally. And then we started getting, at the end of April, beginning of May, the advice to wear masks. And at this point, there were a lot of stories in the US media about the fact that for an African American male, wearing a mask might actually not be an option because they might be considered to be dangerous, to be someone who is trying to hide themselves if they're wearing a mask. So what we did there is that our insight, our intuition was that this probably was true at the very beginning of the pandemic, but as the pandemic progressed, the social norm actually was evolving, but maybe people didn't know yet, so they didn't adjust their behavior to this change in the social norm simply because they were not aware of it. So what we did is we conducted, before the experiment itself, we conducted a survey of people online. We showed them images of people wearing masks, black and white people, and we asked them, how likely is it that this person is protecting the community? How likely it is that they are up to no good? How likely it is that they are sick? And what we found is that 8 out of 10 people told us that the person is, a black person wearing a mask is protecting the community. So with that information in hand, what we did during the main experiment is that for one of the treatment group, we first asked them their priors. What do you think? If someone, we showed them the photo and we said, in your opinion, how many people think that this person is protecting the community? And then we told them, well, in fact, it's actually 8 out of 10 who, when they see this person wearing a mask, thinks that they are protecting their community. So this intervention was effective in terms of updating the priors, and the question was that would it be effective in terms of changing intended behavior at least. So this is the kind of study design and flow for this. So people were randomized. They either were in the treatment group or in the control group. If they were in the treatment group, they had either a concordant or discordant physician. Then they received the acknowledgement or not, and then for the mask study, they either had this social norm debiasing treatment or they didn't. That's an example of our 3 type of physician. We also had this, a female physician, as you could see from the video I showed you. But here is an Hispanic one, a black one, and a white one. What's the main result? So simply comparing already treatment versus control, you can see in this chart that intervention on average affected knowledge. So this graph shows the fraction of people who answer everything right, so they have 0 gaps in knowledge. And the questions here were fairly easy, so it's a fairly high number, but you see an increase from 73% of people having everything right in the control to 80% in the treatment. So this is actually a fairly large impact on knowledge. But in terms of measuring future behavior, at the time, we couldn't do much except for asking them their intent. So what we did is we did something that's commonly done in marketing, which is to have links that people could click through to have access to further information. And we don't see much of a difference in how many people ask for the different links. You can see that many ask for the minimum, many ask for the maximum in both the treatment and control. So it affected knowledge, but we didn't have a great measure of behavior, and this not great but the measure of behavior wasn't changed very much, with the exception of African Americans when the doctor is also black. So you can see here the IIR, basically the odds ratio for wearing for intentions for clicking links, how many links they click, and you can see an effect of 8.5% only for black patient with black physician. So not much impact on behavior as measured by this imperfect measure, and to the extent we find any some effect of concordance. All of the others, so it's a relatively small effect, and none of the other form of tailoring mattered. So in particular, Dr. Burke's was not popular. People ranked her video very low, but this didn't affect their impact on knowledge or the demand for links. The acknowledgement of past inequality in the healthcare system doesn't make any difference. And the social norm intervention, as I told you, affected people's view on social norms, so people understood what we told them, but it didn't affect the demand for more information about masks or other things. So the tailoring, a bit like in the West Bengal study, didn't seem to be that much of a difference. So all of that is interesting, but we didn't have great data on behavior. We had no data on whites. And as the COVID-19 progressed, there was a bit of a COVID-19 fatigue, so maybe intervention would be less effective. And also in the US in the spring, started the racial justice protest, polarization as we got closer to the election. So there was a possibility that this racial effect that we didn't really see in the first study would actually become more salient, and possibly that we would start seeing them potentially in a noxious way among the white population, with possible backlash in response to some of the information. So before we could do anything on a larger scale, we decided we needed a second study of the same format, a slightly fine study with many treatment, to understand what could work out. So in the second study was conducted in September. The objective was to see whether there was still any effect of knowledge, whether with better measure on behavior, we could detect an impact on behavior. And then in terms of tailoring, re-asking the question of race concordance between doctors and respondents. We've slightly updated our acknowledgement module by using a statement put out by the American Medical Association in the wake of the George Floyd killing and the racial justice protest. Most business and organizations felt that they had to express something, have a statement against racism. And what we are doing is that we are randomizing whether the study starts with that or not. So before they see anything, they see a general statement from the AMA, either on racial justice. So the American Medical Association recognized that racism in a systemic, structural, institutional, interpersonal form is an urgent threat to public health, and so on. Or a placebo statement, which is on drug pricing. The American Medical Association believes in transparency in prescription drug pricing, etc. So here is how the study worked. So in this study we had whites and black. We left the Hispanic aside to focus on black and white. They saw either the placebo or the treatment AMA statement. Then they were assigned to a black doctor and to a white doctor. They received either COVID-19 messages, 3 like in the first study, or placebo messages, which were about sports and correct sleep hygiene and nutrition. And then if they got the COVID-19 message, half of them got a reminder that COVID-19 is particularly strongly affected African Americans. Just before we start, by way of background, you might think that one of the reasons why African Americans have more COVID is that because the awareness levels are less high, their behavior is different. And that is what we believed. In fact, that was the whole premise of this intervention. But what we realized is that that's just not true, because it is true that they answer the question less accurately than whites on knowledge. But when we look at their actual behavior, we ask them, do you always wear a mask inside, outside, etc. 45% of African Americans always wear a mask inside versus only 20% for white. And this 20% for white is separated between 30% for Democrats and 50% for Republicans. So in fact, African Americans are much more careful than whites. And in fact, when we look at immunization now, the immunization rates are as high among African Americans and among whites, and much higher among African Americans than among Republicans. But despite that, it could be that the intervention worked differently for black and white, and that the tailoring matters. So what do we find? Key results, as before, we find pretty large improvement in knowledge. You can see many more gaps of 0 and 1 in the treatment group, and fewer of the larger gaps compared to the control group. Treatment group in red, control group in blue. This time we are now finding an effect on behavior through all of our measures. First of all, the demand for information linked increased in the treatment group. So you can see fewer people want 0 link. We also had a willingness to pay elicitation via Baker-DeGroot-Marchand mechanism and people are willing to pay more for masks in the treatment group. This is incentive compatible, because if they ask for a price and we draw this price, we send them the mask rather than giving them their study money. So we find that the intervention increases the willingness to pay for masks, and it also increased adherence to safety behavior a few days after the intervention. You can see that a bit more people do all of the behavior, and a bit fewer people do less of the non-behavior. We also collected donation towards, but we told people that we would select one person at random and implement whatever donation they wanted to make to a COVID-19 focused charity, or to a versus Alzheimer, and to that's the first choice. And the second choice was that for economic relief for Black people in particular versus anybody who's affected by COVID. And you can see that both for both donation, the intervention group wants to donate more to the COVID-19 versus the Alzheimer, and the intervention group wants to give more to the Black charity versus the everyone. So this intervention was quite effective, and there was very little effect of variation in the message framing. Even the small concordance effect we had before vanished. There is no effect of the AMA treatment on anything, no impact of having a Black doctor, no impact of reminding viewers of the separate burden towards Black on either knowledge or intended behavior. Interestingly, not only we find no impact on framing, but we also do not find differential effect by demographic group. Look at the effect on knowledge, for example. This is the knowledge gap, the incidence rate for the knowledge gap, so more means you know less. You can see that the African American have a larger knowledge gap, but they reduce with the intervention. And then the white Republican comes second, and the reduction is very similar. And finally, the white Democrats have the lowest knowledge gap, and their effect is similar. For knowledge, maybe it's not surprising, but what is perhaps more surprising is that that's also true for willingness to pay, and that is also true for the donations decisions that they want to make. For example, for the Black charity, even though white Republicans are much less likely to want to donate to a Black charity, the intervention effect is the same on them. So this is perhaps the most striking results of this second study, is that contrary to the media discourse about polarization that has prevented people to listen to what is being said, people are able to listen to information. And that is true for Republicans, that is true for whites, that is true for Blacks. So it is true that the adherence to the prevention is lower in our study among the white Republican, but maybe it's not because they don't listen when they are being spoken to, but maybe it's because they're just not listening to the same channels. So all of that made us reasonably encouraged that videos can improve COVID-19 knowledge, and that you can also have something very simple. You can have the same message with a diverse group of physicians and just let it roll out, and everybody will hear and benefit. You don't need to tailor very much more than that. And so it turns out that we were interested at this point, and from the beginning our intention had been to scale up this information. And we had the opportunity to do so because Facebook, a team at Facebook approached us after reading the banerjee effect paper to say, oh, well, do you want to do something similar with us? And this was in the fall of 2020. And at the time, the big question was to convince people to not travel for Thanksgiving. If you remember last year Thanksgiving, while you were in Australia, so maybe you don't have the Thanksgiving, but Thanksgiving in last year and Christmas, the big topic was to encourage people to stay home. to not gather together across the United States and spread the pandemic around. Facebook is really a unique network to reach a vast number of people. And in fact, many doctors have tried to take out to Facebook to convey to people they should stay home. So what we did is that we had our doctors, the same that you saw, the same in our first two studies, to record a very short message encouraging people to stay home for the holiday. I'm going to play it for you as it appears on the Facebook site. Let me put it.
To stay home. This Thanksgiving, the best way to show your love is to stay home. If you do visit, wear a mask at all times. I'm Dr. Warner from Harvard Medical School, and I'm urging you, don't risk spreading COVID. Stay safe. Stay home.
So that's the message. This time we didn't vary, we had, of course, doctors of various race and gender and age, but we didn't try to find out the impact of that. We just launched the campaign with a bunch of them. And we did that in Thanksgiving and then Christmas on a very large scale. 30 million videos were sent, and at Thanksgiving, 80 million at Christmas. So about 3 to 4 videos on average. And we randomized the study across the US by counties. So this is the county level randomization. You can see our map. We had to randomize in two stages because the mobility data was going to be available at the county level. But to have a chance to catch an effect on COVID, we thought we needed to randomize at the zip code level. So what we did is we first randomized these white and orange counties are randomized into high intensity counties and low intensity counties. This is the same thing for Christmas. And in high intensity counties, we treat 75% of the zip codes. And in low intensity counties, we treat 25% of the zip codes. And the idea is to look at the effect of mobility. On mobility, we can look at the county level treatment. To look at the effect on COVID, we are going to use the zip level data. The zip level randomization controlling for county fixed effect. So this is how to maximize the data that's available. We only wanted to use public data, so we didn't have any specific arrangement with Facebook in terms of NDA or anything. We just used publicly available data. And Facebook has put together data that they make available to everyone to study the impact of the pandemic. One is a change in movement metric, which is measuring how much less people are moving around compared to February pre-pandemic. So this is the number of tiles through which they are passing through in a day as a fraction reduction relative to pre-lockdown baseline. And then the stay put metrics is the percentage of people who are observed in a same 16 being tile during the course of a day. So here we use leave home, which is 1 minus stay put. In terms of context, this was a moment where the COVID-19 pandemic was really rising. And here is our first result, which is the impact on distance traveled. Our intervention is randomized at the level of where you come from. So we can see an effect on traveling away of your home for Thanksgiving, but not the travel back. So where we should see an effect is really the first few days before Thanksgiving, when people would be traveling to visit their relatives. And in fact, that's exactly what we find. We find when we compares treatment to control COVID in a number of weeks before the holidays, and you can see that it's the same for a while, and then 3 days before Thanksgiving, the travel is lower. On average, over these 3 days, it's about 1 percentage point lower, almost 1 percentage point lower, on a basis of 6 percentage point lower travel in that period. So we go from minus 6% travel to minus 7% travel in the treated place. Same thing at Christmas. You can see the days before Christmas, there is fewer travel, especially day -3 and -4. Same impact, about a 1 percentage point reduction. And then to look at the impact on COVID, we are now looking at the zip code level data. Because there are some zeros, we transform the data with the hyperbolic sign, so you can interpret the number I'm going to show you roughly as percent. And we find a decrease overall across the two interventions, a decrease in the number of COVID cases detected in the treated zip codes of about 3%. So this is Thanksgiving. 3% in the fortnight that start 5 days after the holiday. Now we're looking at Christmas, where we find an effect of 4%, and where we combine the two in a pool regression, we find an impact of 3.5%. So in takeaway is that we detect response to public health messages by medical professionals at scale now via this massive advertisement-based Facebook intervention. The Facebook user seems to respond to the sponsor content. They travel less, and in fact, it reduces the pandemic, which is quite remarkable. There are, in fact, very few randomized evidence of non-medical intervention, which we have all been subjected to. So this is indirectly one of the only evidence that this type of things actually can matter. That's based on an RCT. With the mask study in Bangladesh is another example. Importantly, is the impact was at least at large in heavily Republican county, which again echoes the result we had in the individual level study and shows that people, it seems, can listen to the information even when it's delivered by a quite diverse female group of East Coast doctors. People in Trump counties in the middle of the US, and this still seem to be responding. So in conclusion, despite the ambient noise, despite the politicization, even on topics that appear to be ultra politicized, like travel for the holidays, people are affected by simple messages, regardless of their race, regardless of their politics. In excellent news, we do not find effects that are differential by political parties at the individual or the geographic level. So people seem to be responsive to actionable information delivered by a physician outside of a political campaign. So this is, of course, important for messaging on the COVID-19 vaccine right now. And in fact, we are launching literally any day now, in the next few days, a campaign trying to encourage vaccination in the states in the US where vaccination is very low, both using the exact same type of direct advertisement by doctors, as well as trying to, in another treatment, trying to tell people who have been vaccinated to try and reach out to people they know who have not been vaccinated, perhaps by sharing some of these videos. So that experiment's about to launch, to say that I continue to study this topic. Thank you very much for your attention, and I look forward to questions.
All right. I'd like to thank Professor Duflo for an amazingly interesting talk. I certainly learned a lot, and I'm going to take the privilege of being Dean and ask the first question. and I'm also going to take questions from the chat and present them to you. So let me start by going back to the West Bengal study. So really fascinating. The thing that most struck me is the fact that you didn't find the impact on the content of the message, whether it was, the self-interest message or the externality message. Do you think you would find the same effect in the US if you're conditioned on Republican or Democrat? I mean, are you
So if you look at our second study, which has we don't find any, we find very similar effect on Republican and Democrat viewers, and we find no effect on the tailoring of the message, of the content of the message either. We didn't do internality, externalities, but we did, for example, the bigger burden for the blacks. And the worry, in fact, was that for some people this could lead to a backlash, but we don't find that. So it seems that. So I do think that both findings are hold, that the content of the message is not that important compared to actually reaching out and being present and reminding people that this is important, and that the impacts are quite similar across groups. So I think that probably also in the case of the second studies, that carries out to the content as well. That seems to have. But then we didn't try an empathy versus internality framing in the second study, so I don't know.
So just one question. My background's from, the telecom sector. So really fascinated how these video messages could have such a strong impact. And I think, the Facebook data is amazing that you actually had such a strong reaction. But in developing world, we know, even though we have the widespread adoption of the smartphone, often internet connectivity is very bad or often prohibitively expensive, which would really limit the use of video. Have you thought about what might work in that world? Would it be personalized phone calls, or would text messaging be effective?
Well, I think, more and more of the world has at least 2 or 3G now. So if you're looking at our West Bengal study, it was video based. It was in rural West Bengal, and everybody has access to some form of internet on their phone. It's not great, but it's enough to see a short video, and they do watch many. So I think that in some sense, I think in most part of the world, that's not really a question anymore. They don't have enough internet to go to school or to do a Zoom call, but they have enough internet to watch a small video.
Okay, great. So again, one question from the audience. West Bengal has a large Muslim population. Did you do any study to think of the religious affiliation of the messenger as well in West Bengal?
No, we didn't. Well, this particular, that's a great question. This study was so large that we definitely have both Muslim and non-Muslim areas, but I don't think we looked separately at the impact. We should.
Okay. And then one other question is, you mentioned this at the start. I know, some of your early work in the papers with, Matt Jackson, for example, look at who to contact to exploit the social networks. Have you been looking at that in this context at all? Or?
Yes, absolutely. So we are not. We haven't done the study yet. I mean, we are about to launch a project like that in India, where we're hoping to do. Backtracking a little bit, in work with Arun Chandrasekhar, Abhijit Banerjee, who are both in this paper on this, and with Matt Jackson, we've looked at childhood immunization and tried to identify the people from the network who are very good at conveying information, and we call these people gossips. Mm-hmm. So for the US study we are conducting now, we did 2 things. So first is we are sending people a video asking them to share the message to their friends. So we don't know that we've reached gossips, but we have at least reached people who hopefully will be willing to talk to their friends. The second thing we are doing, which is a little more subtle, is we tell people, think about the gossip in your network. Think about the person who is the most effective at spreading information, and see whether you can ask them to convey the information to others. So basically, we're trying like an on-the-fly elicitation of who is a gossip, where I don't know whether it's going to work or not. in India, we are actually working with the insurance, health insurance, state government health insurance. They have a huge database of people, and we're going to call many of them and ask them to give us some names of people they can think of who would be good ambassadors of immunization. And by telling them, by asking them, who has many friends, who themselves have many friends, so that when they know something, everybody comes to know about it. And then we're going to try to enroll them in an immunization campaign for COVID, since we've done something similar for childhood immunization and we found it to be very effective. So that's the idea, but that's not launched yet.
That sounds fascinating, actually. Look forward to that one. We have one other question, which I think, going out on a limb, relates to, bear in mind your earlier work on diff into diff. It's an ambitious question. Given the work that you've done, where we look at the difference, the impact of behaviour changes on racial groups, if we go back to the starting point of systemic racism and the impact of COVID, do you think from your study we could actually tease out from the difference in behavior how much of the initial impact is due to a systemic racism versus behavior?
Yeah, so I think so. I think what was very striking is we started with the wrong premise in a way, because we really thought that a big part of the difference was behavior, and the difference in behavior was itself related to perhaps misinformation that could be corrected. But in fact, it was wrong. The premise was wrong, because the behavior of African American is so much more careful. Mm-hmm. So what does it leave, what does it leave? Well, it has to leave structural racism. It has to leave the factors that have either, economic discrimination, historical or current, and or the way that the black population is treated when they reach the healthcare. So basically, we are left with saying there's not much that has to do with behavior, because the behavior is actually so much more careful. It has to be the rest when you're seeing. It has to be pre-existing conditions, which themselves are sort of the lived embodiment of past racism, plus the way that the healthcare system is treating them, plus the economic condition, for example, which meant that they were much more likely to still be frontline workers and the like.
Yep, fascinating. So we have, I think, time for one last question. It's rather long. Let's see if I can paraphrase it. One of the challenges of the pandemic seems to be the quality of the national level messaging, e.g. by the president, Dr. Fauci, or other national officials. Mistakes in such messaging seem to embolden the skeptics. What lessons do you think you have from your research on combating these mistakes?
Yeah, that's a great question. So actually, one of the authors of this study is a wonderful graduate student at MIT called Pierre-Luc Vautret, and he's run another study on exactly this question of this wavering in the communication at the beginning of the campaign, and minimization by the Trump administration of the disease and all that. And it shows that that has a lot of impact on people's willingness to act on information that is given to them. So if you have a sense that, for example, that the government was initially minimizing the pandemic, then when the government gives you a number, you don't really going to believe it. So that really shows the cost of such missteps in statements. But I think what this shows is that there are many, there are flows of messages, and the impact doesn't seem to be very durable. For example, in the Thanksgiving Christmas work, we have an impact the impact of the Thanksgiving campaign doesn't last till Christmas. Presumably also the impact of bad information doesn't either translate, last over time. So I think we need to combat misinformation by information, just put it out there. You know, I was saying that if people have the information, what this shows is that if people have the information, they'll listen to it. So I think the biggest problem we have is the problem of echo chamber and algorithms that are pushing the same type of information to people that is, you know, in some cases will be accurate, in some cases will be inaccurate. And based on our study, my response at the moment would be that we should blanket the countries with information that is accurate.
But yeah, but keeping it on a continuous basis.
Yeah,
that's fascinating. So we're actually at the end of time. We still have a few more questions in the chat, but I'm afraid it's quite late for you, and I want to thank you for the generosity in your time and for this wonderful seminar. And I want to thank our enormous global audience for joining us today, and look forward to hopefully seeing you in person at some stage soon. Right.
Thank you. Looking forward.
Everybody.
Thank you.
Thank you, Esther, for the invitation.
Thank you, Esther. Good night.